Ms. Sahiti. You're on. Good evening, one and all. On behalf of the OBGYN Pulse Midweek webinar series, this day being the episode 4, I welcome you all faculties and delegates on behalf of Dr. Vijaya ma'am. Can we have the next slide, please, Ms. Sahiti? So talking about Vijaya ma'am, she has been the convener previously of an Aksharam webinar series. She is now the convener of the academic series called OBGYN Pulse Midweek webinar series. She has a vast experience of about 30 years in teaching the PGs and the UGs. Ma'am is the candidate for chairperson for Foxy Medical Education Committee 2025. We wish you all the best, ma'am, and we really hope that you have that in your hands because you have done so much for academics. She is the president of OGSI in 2024 to 25, former director of IOG, and she's the former director of Institute of Social Obstetrics and Gynecology, MMC 2013 to 19. And she has been awarded the Best Doctor Award during the COVID pandemic for her excellent skills and works at that time. And she's been the member of Foxy and Oxy committee for years together. And she has a very, very vast teaching faculty. She's been the teaching faculty with vast teaching experience, as I told you already. And she has been the faculty for all the revision courses here in Tamil Nadu, whether it is UG or PG. She's been a state level master trainer in the emergency obstetrics and neonatal care. She's also been a part of the cervical cancer screening and colposcopy. She's the state level master trainer in the same. And she's a national master trainer in self-delivery practices and in Dakshita. And she's a Foxy master trainer in HPV awareness programs. So some of the other programs you would have definitely met ma'am. And she's a scientific chairperson for the Foxy President Conference of 2024 as well. She's worked a lot and she's played a key role in the Lakshya certification for IOG, ISO KGH, and the ESI, the one in KK Nagar, Chennai. And she's been an examiner for the undergraduate, postgraduate, MS and DNB examinations. A very nice examiner who always helps the students to give their best during the exams too. So the conductor of Aksharam academic webinar series from 2024 to 25 and the convener of the OBGYN Pulse academic series of 2025, the person who is into academics for the last 3 decades. I welcome the convener of today's webinar, Dr. Vijaya ma'am, to host the session, please. Ma'am, over to you.
Thank you, Madhu, for such a lovely introduction. That too from a student. It's really heartwarming for me. Can I have the slide of Madhu, please? Yeah, she's always with me because she is not at all involved in obstetrics, but nevertheless, she's a fertility physician. But I just said, Madhu, you be with me for this webinar series. She is always with me since the beginning. And I choose the first topic and she will choose the second topic. It goes parallelly. The OG and the IVF, the journey goes parallelly. Madhu's an MBBS, DNB and MRC OG. She has a diploma in gynae laparoscopy and she is a fellow reproductive medicine from M. And she's a clinical director and senior fertility physician from Nova IVF Fertility MRC Nagar. She has many papers and posters awards from Oxy, RCOG, AACOG, UISR, Youth Icon Award and Best Paper. And she has very good publications in BJOG and UCP. And just go above, no? Her special interest is in, just go above, Sagiti? It's cut.
Okay.
Yeah, what is that?
Yes, ma'am.
Yeah, what is that thing, Madhu?
Ma'am, I'm interested in onco-fertility and also to give biological hair for all people, poor ovarian or poor sperm reserve patients.
That is one the important thing. Biological hair for all people with poor ovarian reserve. Yeah, this is very, very good. And thank you, Madhu, for being with me.
Thank you so much, ma'am.
Okay. Yeah, Sagiti?
So here we go. We start with lighting of the Kutuvelako and the prayer song today.
Gynecology. गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you, Sariti.
Thank you so much. So with that intro, we go into the two lovely sessions of today's webinar. Can we go to the next slide, please? So the session 1 being screening of ovarian cancer. We have our own chairpersons and the speaker ready for the first session. Can I take the privilege of asking Dr. Vijaya ma'am to introduce the chairpersons and the speaker, please, ma'am?
Yeah, I have great privilege in introducing my chairpersons from Foxy, Dr. Vaishali, President of Jalegan Obstetrics and Gynec Society, and she's the past Vice President of Jalegan Obstetrics and Gynec Society and past Secretary also, and she's a practicing obstetrics and gynecologist at Siddhivinayaga Hospital in Maharashtra. Welcome, Vaishali. And I have great pleasure introducing Kalpana, and she's a consultant obstetrician and gynecologist and gynae endoscopy surgeon at Chandrapur. She's the president of COX at 2025-26, and she is an organizing secretary of AMOX at Chandrapur, advisory member of PCPNDT committee, secretary IMA 23-24, best secretary state and national IMA 23-24, secretary COX 2004-6, vice president from 2016 to 18, Vice President IMA 2021-22, President's Arushi Social Network Foundation, finisher Ironman 70.3, Duisburg in Germany and Goa, full marathoner, very good, Berlin World Marathon, and special interest is the hysterolaparoscopy and obstetric ultrasound. Hobbies are cycling, dancing, gardening, and marathon participation. Yeah, Kalpana, very, very interesting. And I have the pleasure of welcoming Dr. Sujata, consultant obstetrician, gynecologist, and female fertility specialist. She has done her MBBS and DGO from NKP Salve Institute of Medical Science, Nagpur. Recipient of the first late Dr. Leela Dubey Gold Medal. She's a work experience as a gynecologist obstetrician from Solapur, 2002 to present from Banshankari Devi Hospital. Worked as a medical officer at Solapur, Palika for 8 years. Gynec and obstetrician in Ramakrishna Hospital, Solapur for 4 years. And she has a lot of community involvement. She's a current president of Solapur OG Society, past vice president of Solapur Society, past honorary secretary and clinical secretary of SOGS, and executive member of SOGS. And she has female infertility, adolescent health, and public awareness. Welcome, Sujata. Yeah, now I have the pleasure in introducing my very own student, Dr. Raja Tarangani. What more a teacher can get when a student surpasses the teacher and goes to greater heights. That is the greatest privilege I have in introducing Raji. And she's the managing director of Dr. Mani's Oncobase Cancer Center, Pollachi. And she has done her MBBS, MS, and also MCH in Kidwai. And she has done her MS in Government Kasturba Gandhi Hospital, KGH, when I was the director. And areas of interest are gynae oncosurgeon and specialist in oncosurgery. And very soon she'll be starting a state-of-the-art onco center where radiation, chemo, and surgery, everything will be together. And I'm waiting for the date, Raji. Over to you and welcome you and very privileged.
Thank you, ma'am. Thanks for my wonderful introduction, ma'am. It's my privilege to present my topic in front of all these great chairpersons. Can I start the topic, ma'am?
Yeah, please share.
My screen is visible, ma'am?
Yeah, visible. Make it full screen. Yeah.
So we are going to see the topic of screening of ovarian cancer today. Actually, we have various kinds of screening for cervix. We have even endometrial screening in high-risk patients. But still, this ovarian carcinoma screening is actually a controversial topic since today. So we'll see what are the highlights of this ovarian cancer screening. So statistics, when we see this, ma'am, am I audible properly?
Yeah, audible. Very
Okay.
much.
Okay, ma'am. Statistics of ovarian cancer, when we see it is the third most common gynecological cancer among women after cervix and uterus in India. But it is the deadliest cancer. My screen is not moving.
Miss Sahiti, can you help her out, please?
Click on it again. Maybe it's stuck.
Yes, ma'am. It is the leading cause of cancer death among women. And one second. And the incident rate, age-adjusted incident rate is adjusted between 5.4 and 8 per 1 lakh women population. So when we see this gynecological cancer, cervix is still the most common gynecological cancer among women in India. Next comes the corpus uteri and then the ovary. But when we see this blue line shows the incident rate, whereas this orange one is the death rate. So when we see the incidence of cervix cancer, it is the highest, whereas the death rate is around 60% of the cases. Whereas when we see the ovary, among the diagnosed cases, almost 75% of cases ends in death. This is because of late diagnosis. So when we see this pie charts also, ovarian cancer incidence is about 22%, whereas the death rate toll increases up to 32%. This red one indicates the ovarian cancer. When we see in countrywide, China stands first. According to 2022 status, China stands first among the ovarian cancer incidence, whereas India comes in the next position and US stands the third. One death rate, when we consider among that, India stands always first among the death rate of ovarian cancers in India. It is because of late diagnosis and poor screening methods that are followed in India. So lifetime risk of ovarian cancer of being diagnosed is about 1 to 1.5%. Of dying out of ovarian cancer after diagnosis is about 0.5%. We already know about the risk factors of ovarian cancers. The increased risk factors for ovarian cancer is increased age. That is, aging is a major risk factor. Apart from that, family history of ovarian cancer, family history of any cancers, hereditary cancer syndromes, obesity and nulliparity, hormone replacement therapy, and increased number of lifetime ovulatory cycles. And decreased risk of ovarian cancer can be by bilateral salpingo-oophorectomy and only oophorectomy, or bilateral salpingectomy with ovarian retention, hysterectomy, tubal ligation, and use of oral contraceptives, and even breastfeeding. So why we need this cancer screening for this ovarian cancer? Because it is the leading cause of death from all gynecological cancers, and 70% of them we are diagnosing only at the advanced stage. And this low rate of early detection has been attributed to the rapid and aggressive growth pattern, because once the symptom arises, the case is diagnosed as cancer within 6 weeks to 8 weeks lifespan. Then lack of specific and reliable symptoms in the early stage, because we already know the ovarian cancer has very vague symptoms like bloating, loss of appetite, abdomen distension, which is actually very common symptom in with menopausal ladies. So they mistake these symptoms as just a physiological symptoms, but still these are the specific symptoms for ovarian cancer also. So this is how we are missing many cases of ovarian cancer. So if we screen them early, we could early save their lives. So when diagnosed earlier, the survival would be better. This is how the stage 1, the 5-year survival rate is 80 to 90%, whereas in stage 4, the 5-year survival rate comes down to only just 25%. But we have to know this, that majority of the ovarian cancers are diagnosed only in stage 3, where the survival rate falls down to 35%. So this suggests that screening may help save lives by detecting the disease earlier, improving treatment outcomes and the survival traits. So risk stratification, how do we stratify the people whom are going to screen? So we can group them into 3 groups, 1, 2, and 3. The group 1 belongs to women with a risk of level near to that of general population. That is the normal people where we encounter daily. And group 2 is women with increased risk, and group 3 is women with inherited risk due to known genetic mutations. So women with level of risk near that of general population will have a relative risk less than 3 times the relative risk of the general population. Who are they? This category includes women with any of the following: a history of breast cancer diagnosed at the age of 40 or older, and no family history of breast cancer or ovarian cancer, or no Ashkenazi Jewish hereditary, or a history of infertility or use of ART such as IVF, a history of endometriosis, or a history of HRT use. Women with increased risk, that is relative risk 3 to 6 times greater than that of general population, includes the following category: a first degree relative with ovarian cancer who might be a mother, sister, or a daughter, and a personal history of breast cancer diagnosed prior to age of 40, or a personal history of breast cancer diagnosed prior to age of 50 with one or more close relatives diagnosed with breast or ovarian cancer at any age, and more than 2 close relatives diagnosed with breast cancer prior to age of 50, or with ovarian cancer diagnosed at any age, or an Ashkenazi Jewish heritage and a personal history of breast cancer prior to 50, or an Ashkenazi Jewish heritage and a first or second degree relative diagnosed with breast cancer prior to age 50, or an ovarian cancer at any age. People who are with inherited risk due to known genetic mutations, that is relative risk greater than 6 times that of the general population. This includes the women with any of the following, that is this BRCA1 and BRCA2 mutations, or this mismatch repair gene mutations like HNPCC syndrome or Lynch syndrome. Apart from this, we have known many other mutations like HRD groups, which are not actually diagnosed very early. So whom to screen? In an average risk, that is the group 1 and group 2, group 1, it is not recommended, whereas in high risk, it is always recommended. So what is the effective screening test? Let us see. A screening is a means of detecting disease early in the asymptomatic people. So actually, many people will be reluctant to get diagnosed with cancer nowadays. So the screening method should always, an effective screening method should always be a safe, reliable, acceptable, affordable, and highly sensitivity and specificity with a positive predictive value. So what is the effective screening test that we could opt for this ovarian cancer? That should have a sensitivity of at least 75% and a specificity of more than 99.6%. That has a very high specificity, and positive predictive value at least a minimum of 10%. So why the screening is always a challenge in this ovarian cancer? Because anatomically, ovary is deep seated in the pelvis, which is not easily accessible in clinical examinations in a normal sized ovary, and it doesn't have any precursor in situ lesions, which is well defined things. And the progression time from localized lesion to the disseminated tumors is always unknown, and there is no specific marker. Though we say CA-125 is always used for this diagnosing this ovarian cancer, it is not a specific marker. I'll tell you in the later slides. And it is actually a low prevalence disease, ovarian cancer. It needs exquisite specificity to avoid unnecessary interventions, because the false positive results because of anxiety, it might result in dangerous surgeries, and delayed diagnosis due to lack of severity and specificity of the early symptoms. The symptoms of this ovarian cancer, when we say, we call it as COPE symptom index, which is actually non-specific symptoms, as I told, like bloated abdomen, abdomen distension, excessive flatulence, and dysuria, abdomen pain, which is actually a non-specific thing which occurs commonly in menopausal ladies. So what are the screening methods we can opt for this ovarian cancer screening? Pelvic examination, this is the first and foremost thing, and tumor markers, and then ultrasound screening, or a multimodal screening which involves all these three. Or always include a genetic screening when we suspect the person might be having a genetic mutation. So pelvic examination, when we do a pelvic examination, we can identify the size of the tumor, shape, consistency of uterus, ovaries, or any mass in the pelvis or its characterization like irregular surface or mobility like that. But it is difficult to diagnose all these points in an early ovarian cancer where the size of the tumor will be very small and it will still lie in the pelvis. In that case, we will need the additional tests like CA-125 along with USG. So in high-risk women, it is recommended to do annual pervaginal examination beyond the age of 18 years with the consent of the ladies. And beyond the age of 35 years, she should undergo always a rectovaginal examination. Tumor markers, it is a tumor biomarker in the blood or which is easily available in the body tissue would seem to be an ideal screening strategy. In this case, we can use many screening markers, but the most popular is CA-125, HE4, CA, and CA-99. Along with that, when the woman is less than 40 years of age, less than 40, we have to use this germ cell markers also, which is this alpha fetoprotein, LDH, and the beta HCG. And CA-125, when we see this is the most popular and extensively studied biomarker, it is a glycoprotein cancer antigen 125. It is detected in blood and also in serum and also in the body tissues. And it is expressed by tissue which is derived from the coelomic epithelium. So it is not only from the ovary, it is from the peritoneal surface, from the pleural and also the pericardial surfaces also. And the normal range is typically between 0 to 3 units per ml. And it is elevated in 50% of cases in stage 1 serous cancers and 80 to 90% in advanced serous cancers. It is a useful marker to guide the response to treatment and monitor during follow-up. We have to note this. This is CA-125 as an oncologist, we mainly use for the guiding the response to treatment and monitoring during follow-up because as it is a non-specific marker. It is not an ideal and sole screening tool. That is, I'm not telling that we can't use CA-125. We can use CA-125, but not as a sole, not as a single marker. Because it has a very poor sensitivity, 70 to 75%, and poor specificity, that is 90 to 95%, because it is elevated in other benign conditions, even during menstruation, pregnancy, all fibroids, endometriosis, pelvic inflammatory disease, even in liver cirrhosis, even a 1% healthy woman can have a mildly elevated CA-125 levels, and appendicitis, diverticulitis, renal failure, and inflammatory bowel disease. The thing is, anything which irritates the peritoneum or a pleura will cause elevation in CA-125 because it has formed from the coelomic epithelium. Apart from this benign condition, even malignancies like pancreas, endometrium, breast, lung, colon, lymphomas, and mesotheliomas could also have this raised CA-125 levels. So, we can't use it as a single marker, but the addition of other markers might improve the sensitivity and the specificity. How could we do this? We can do this ROCA algorithm, that is risk of ovarian cancer algorithm. Here, what we do is we include, it is a quantitative algorithm. Here we include the woman's age, menopausal status, and we carry the history of personal ovarian cancer risk and also the CA-125 values. We do a CA-125 test serially, that is longitudinally, once in 3 months or once in 6 months or annually according to their risk. And then we calculate this risk of ovarian risk, ROCC calculation. If it is normal, they will undergo a normal test. Otherwise, if it is intermediate, every 3 months we have to repeat this test. If it is elevated, we will directly go for evaluation of cancer. So apart from CA-125, we have this recently introduced this human epidermis protein 4, that is HP4, which is more popularly entering into this clinically. So here it is a protease inhibitor expressed by the malignant epithelial ovarian cells. We have to listen well. It is expressed by the malignant epithelial ovarian cells, not by the benign cells. So it might be little specific than CA-125, and it is raised in 50% of epithelial ovarian cancers which do not express even the CA-125. So this HE4, when we have a doubt that whether this mass could be a benign or malignant, in that case we can use this HE4 to differentiate between a benign and a malignant. It has a greater sensitivity, highly specific than CA-125 alone, and the cutoff value for premenopause is 70 picomoles per liter, whereas for menopause it is, postmenopausal ladies, it is 140 picomoles per liter. So what can we do? Can we combine the CA125 and HE4? Yes, obviously we can combine. So it will become the best biological diagnostics tool in predicting the high risk of ovarian cancer in patients with suspected benign ovarian tumors. If both is increased, we have to go with definitely with higher investigations. If either one is increased, we have to go with other kind of imaging modalities like ultrasound, CT, or any other biological monitoring. So this CA125 and HE4 is combined in an algorithm called ROMA. It is called risk of malignancy algorithm. Here we include CA125, HE4 and the menopausal status. Now the test has increased the sensitivities and specificities in both menopausal and premenopausal, but comparatively when we see the postmenopausal women have a very good diagnostic procedures in this ROMA algorithm. So in 2011, FDA approved this ROMA to determine the risk of ovarian cancer in women who has presented with a pelvic mass, because HE4 will diagnose whether it is a benign or a malignant mass. So OVA1 is another predictor tool. Here we use the serum levels of 5 serum proteins like transthyretin, apolipoprotein, beta-2 microglobulin, transferrin and CA125 also. Along with that, menopausal status is also included. But the practical difficulty is there where this all 5 serum proteins will not be able to get tested in all the centers in the peripheries also. So it is not approved for using for screening in this patient. So then comes the OVA2, which is also called OVIRA. Here they replaced this beta-2 microglobulin from OVA1 with HE4 and FSH. So here what they did is to improve the specificity and positive predictive value of OVA1 and maintaining the high sensitivity and negative predictive value, we have included HE4 and FSH. So here we can stratify the patient with an adnexal mass into the high risk or low risk categories, and the sensitivity now has improved to 91%. And the overall score along with physician assessment, if we do, the sensitivity will improve to 94%. So FDA has approved this OVA2 in 2016. And USG, when we see, we can do either a transabdominal USG or a transvaginal USG. But nowadays, we prefer transvaginal ultrasound, which has a better resolution and it could characterize the morphology of the ovarian tumors and it allows earlier stage detection. But the limitation is it has a very positive predictive value in asymptomatic women and it has inability to detect malignancy in a normal sized ovaries. But the addition of color Doppler along with USG might distinguish benign from the malignant things. And moreover, ultrasound is always a subjective method of detecting anything. So here, what we can do is ultrasound. Now we have included this B features and the M features in a score called IOTA scoring, which is called International Ovarian Tumor Analysis Scoring. Here we have this ultrasound features of M1 to M5 and B1 to B5, which is called M features and the B features. M features include, I will tell only the M features. The M features include irregular solid tumor with the presence of ascites more than 4 or equal to papillary structures, and irregular multilocular solid tumor with the largest diameter of more than 10 centimeters and a very strong blood flow. That is, the Doppler color score should be more than 4. If even one or more M features are applied, in the absence of B features, the mass is classified as malignant one. And if one or more B features apply, in the absence of M feature, the mass is classified as benign. If both is present or both is absent, in that case, the mass is classified as non-classified mass. So here the sensitivity improves when we characterize the feature of the mass. The sensitivity now raised to 91.6% and the specificity is also good. And the accuracy is 88.8%. So ultrasound with IOTA simple rules. What are the advantages? When we see the ultrasound, it is easily available. It is low cost. There is no radiation exposure, but it is more subjective. The only negative thing with ultrasound, it is more subjective than any other modality. But when we add this IOTA score, this is called simple ultrasound rules. This could eliminate this subjectivity because of high sensitivity and specificity. And we can even reproduce and it is easy to train and use it regularly. So we would always recommend this ovarian cancer screening with this IOTA scoring, that is simple rules. And other scoring has evaluated like called ORAT score. Nothing like this. In breast, we call it as BIRAT score. In thyroid, we call it as TIRAT score. Similarly, in ovaries, we have this ORAT score. It is nothing but the risk stratification according to the percentage. ORATs 1, 2, 3, 4, and 5. in which ORATS 1 is normal ovaries with no malignant risk, ORATS 3 is low risk of malignancy, and ORATS 5 is high risk of malignancy, that is more than 50%. So multimodal screening. Here we include both CA-125 and ultrasound screening, either performed sequentially or concurrently, which is the best mode of treatment, where in ultrasound we will also assess the IOTA scoring. So now coming to the most popular, which every one of us will know, which is called the risk of malignancy index, that is called the RMI score, which is now peripherally used. Here we have this RMI 1, 2, 3, and recently RMI 4 has evolved. In this RMI 4, nothing but actually in RMI 1, 2, 3, we use only CA-125, menopausal status, and the ultrasonogram score. In RMI 4, we have included a feature called tumor size score. If size is less than 7 centimeters, score is 1. If it is more than 7 centimeters, the score improves to 2. So when we calculate this RMI in 1, 2, 3, and 3, we calculate as CA-125 value and the menopausal status and the ultrasound score. Whereas in RMI 4, we are including into S, that is the size. If the RMI score is above 200, the sensitivity is 85% and specificity is 96.9%. Still, we have to note, which I told you in the already discussed slides, the specificity has to be more than 99%, which in this RMI, it has not met that also. So when we see the ROC curve, in this ROC curve, the specificity, the sensitivity of this ROC curve, when we see this purple line is RMI 4, here the sensitivity of RMI 4 is very high, whereas when we see the specificity, it is equal to that of RMI 3 also. When we compare all these RMI 1, 2, 3, and 4, what is best is the specificity of this RMI 4 and the positive predictive value, which is high, which is still higher than 1, 2, 3, but still it has not met the prerequisite for an ovarian cancer screening tool. So what we can do, whether we can use this IOTA scoring or the risk of malignancy index scoring. IOTA is what nothing but the M features and the B features which we calculate, whereas this RMA is based upon the menopausal state, CA-125, everything, ultrasound score, everything is included in this. But when we see this ROC curve, the sensitivity of this IOTA, that is this green one, is very high. IOTA score still has a very good sensitivity, and it is superior to RMA in detecting the malignancy. So we always could recommend ultrasound CA-125 and ultrasound with this IOTA scoring. And coming to genetic testing, it is offered to those who are likely to have an inherited mutation, because based on the personal family history of breast cancer or the ovarian cancer, we can know this risk factor, but it is not routinely performed on an average risk patient. And BRCA1, BRCA2 mutation accounts for the majority of cases, but still all the mentioned mutations which I am showing in the screen, like P53, P10, CDH, MLH, MSH2, MSH6, and PAL check, RAD, everything has to be checked, because only 50% of the mutations is caused by BRCA. Remaining is caused by the HRD genes, which includes all these. So multi-gene panel testing, that is called the NGS testing, next generation sequencing testing. Indication, personal or a family history of ovarian cancer or a family history of breast ovarian related cancers. Triple negative breast cancer is a very high risk for developing ovarian cancer, and male breast cancer and the Ashkenazi Jews. And the benefit, we can early identify, personalized management and risk reduction, informed decision making, and also for targeted therapies. During chemotherapies, we use this targeted therapy to target that particular gene, which is that BRCA or a P53 or a RAD, so that we could knock down the gene and then give a very good prognosis for the patient. And the considerations of this testing is cost. It is still at a higher cost, and average people cannot afford to do that. And incidental findings of other pathological genes. That is, as it has a wide panel of genes, we will also find not only BRCA, other genes might come positive, which has the risk of other kind of cancers like pancreas, prostate, and other things in case of males. And psychological impact with the positive results. So we always emphasize that only after the completion of family, we would recommend to do this testing practically. Actually, we have to do whenever we have a high risk, but still, as it has a very high psychological impact with a positive result in teenagers. So we recommend it mostly beyond 25 years, and it has a limited clinical management guidelines for some genes in the panel. So what are the major trials? There is various trials regarding this ovarian cancer screening. This Kentucky study, it was a single-arm prospective study. It was done in an average risk women, not in a high risk women. They did it in average risk women, they said that questionable cost of effectiveness was there using transvaginal scan annually for an average risk group. And when we see this PEL-CO trial, which is a very famous trial where they screened prostate, lung, colorectal, ovarian together in a general population, that is an average risk population, they took as an RCT, that is randomized control trial. Here they randomized into control arm which received the usual care, that is only the pelvic examination, whereas the intervention arm they screened for prostate, lung, colorectal and ovary. But finally they too concluded that does not reduce the ovarian cancer risk mortality. Whereas this UK CTOCS trial, which is a collaborative trial of ovarian cancer screening, it is also an RCT. Here they randomized into 3 groups, which had a multimodal group and an annual transvaginal ultrasound only group or a no screening group. Here when we see that no screening group had a high risk of mortality, whereas this multimodal group and the ultrasound group had a somewhat a near reduced risk of mortality, but the difference was not significant in case of p-values. So the benefit is relative mortality reduction was there, but when they were screened beyond 7 years, it was there, but less than 7 years, the screening mortality reduction was not there. So when there was no significant difference in mortality with screening, they told that proportion of diagnosis in early stages was increased, but still the screening had a very poor results. So when we see the screening of ovarian cancer systematic review with the US Preventive Services Task Force, what they analyzed is, suppose if you are detecting cancer, screening test positive, that screening positive patient would undergo some kind of surgeries or psychological impacts. That was analyzed in this systematic review. What they told is, in all these studies, this UK CTOS or PLC or a UK pilot study, the ovarian cancer mortality did not differ within women, but it included a risk of high false positive surgeries and with major surgical complications. And also this UK familial cancer screening study. So far, I have discussed only the average risk women screening, whereas this is the study which was conducted in women who had a familial risk of ovarian cancer. Here they tested with CA 125 4 monthly with ROCA and transvaginal scan annually. Here they concluded that strict adherence to the screening schedule more frequently than annual screening is better for early detection and surgical intervention. And even a ROCA based screening can be done for women who decline RRSO. RRSO is nothing but the risk reduction salpingo-oophorectomy. So this is the study called ALDO, where this ROCA was replaced with RRSO. See, whenever we diagnose that we are having a screening positive, in that case, women will be very apprehensive to do further tests. So in that case, they will be very apprehensive to do further surgeries also for reducing the risk. For them, we can use this ROCA test 4 monthly instead of this RRSO. So we have this multi-panel markers also nowadays, like CA 125, CA 19, EGFR and everything. Now it is actually in evolving phase. When we see the guidelines, all these guidelines like ACOG, ACS, American College of Radiologists, American College of Family Physicians, RCOG, or a British Gynecological Cancer Society, every guideline says that there is no screening test proven to be effective and accurate in early ovarian cancer, and it does not recommend screening in an average risk women, and evaluation of high risk women may include transvaginal scan, CA 125 testing in addition to the physical examination. Even ESGO, which is European Society of Gynecological Oncology, guidelines regarding ovarian cancer states that there is no routine screening for asymptomatic women. We have to focus on early detection of symptomatic women and appropriate diagnostic workup for the suspected cases. Even when we see this European Society of Medical Oncology, they also say that when we have BRCA testing positive in BRCA 1 and BRCA 2, we have to screen them with 6 monthly transvaginal ultrasound and CA 125. And we have to do an RRSO, that is risk reducing bilateral salpingo-oophorectomy at the age of 35 to 40 in case of BRCA 1 and at the age of 40 to 45 in case of BRCA 2. And when we see this NCCN guidelines, which is National Comprehensive Cancer Network, which is the famous guidelines used by all oncologists during their practice, This guideline says you have to focus on identifying and managing the individuals at high risk of ovarian cancer population rather than screening the general population, because individualized management is always recommended for surveillance and risk reduction surgery or other management strategies. So what does this NCCN guideline states? In an average risk women need not do any screening because it can result in high false positive rates. And in high risk women, risk assessment has to be done and genetic test has to be done, and enhanced screening along with the genetic testing and transvaginal ultrasound and a higher imaging like MRI and CA-125 can be done. Suppose if BRCA comes to be positive, what should we do? In case of breast cancer, prophylactic methods like at the age of 18 years, the girl has to be aware of her own breast, and clinical examination has to be done every 6 to 12 months starting at the age of 25, and beyond 25 to 29 she has to do annual MRI, and beyond 30 years annual mammogram and breast MRI with or without contrast has to be done. In that case, if it is a male breast cancer positive, in that case we can start the screening for men at the age of 35 years. So for ovarian cancer, if BRCA is positive, what could we do? So the age of the patient has to decide the management what we are going to proceed with. If she is in a reproductive age group and if she is nulliparous, she can go for IVF because she can't delay her pregnancies. She can go for the options like egg or embryo cryopreservation, and consideration of pre-implantation genetic testing is very important because the kid might, the baby might also come to be a BRCA positive baby. So non-surgical risk reduction management, still we have it, but this is still under the studies. We can opt for oral contraceptive pills or an LNG IUD. This also says there is a little reduction risk of ovarian cancer, but only in an average risk population. Always in a high risk population, surgical risk reduction is the only strategy we have available now. So in that case, what we have to do? For risk reduction surgery, it is not recommended in RRS, that is risk reduction self-injectomy.
5 more minutes, Raji.
Okay, ma'am. We'll finish in 2 minutes, ma'am. Risk reduction self-injectomy alone is not recommended in pathological BRCA mutation variant. That is, I'm mentioning only self-injectomy alone is not recommended. Interval self-injectomy with delayed oophorectomy is under trial, and RRSO, that is risk reduction self-injo oophorectomy bilaterally, is recommended for individuals with pathological BRCA testing. So what kind of RRCA we can do? In BRCA 1, 35 to 40 years, BRCA 2, 40 to 45 years, the surgery has to be done. During the surgery, peritoneal washing should be performed, and the pathological assessment should include CFIM protocol. It is not only removing the organ, it has to undergo histopathological examination based on this CFIM protocol to identify the pre-invasive lesions. And the benefit of 50% risk reduction in breast cancer is also there when we do this bilateral salpingo-oophorectomy. So Memorial Sloan Catering also recommends that average and increased risk, no evidence of screening decreasing the mortality, whereas in inherited risk alone, we can do this testing. And now the future is not only towards the CA-125 and transvaginal screen, the various biomarkers has evolved and genetic aberrations can be tested, and cell-free DNA, circulating tumor cells and non-coding RNAs, along with this uterine lavage with duplex sequencing for genetic analysis is also evolving for this diagnosis of this ovarian cancer. So the final take home message is screening average risk women in general population is not at all recommended, and CA-125 and transvaginal ultrasound is not recommended. Single value is not recommended for screening, and transvaginal scan 6 monthly along with CA-125 along with ROCA as multimodal screening is more effective in detecting this early cancer in high risk and inherited group, and this should be started at the age of 35 years of age or 10 years prior to which the family member was early diagnosed. And multi-gene testing, that is this next generation sequencing testing, should guide the risk reduction strategies in inherited and high risk groups. Thank you, ma'am. Now open for questions, ma'am.
Wonderful, wonderful. And the PGs, I really hope they must have watched all these trials. And then finally, the disappointing thing is there is no ovarian cancer screening for average risk women except for
Yes, ma'am.
genetic. So no use in doing the transvaginal or whatever it is, except they have a family history. Yeah, very nice, Rajitarangini. There
Thank
was
you.
one question, maybe one question we can take.
Yes, ma'am.
Yeah.
Can I have a question?
Yeah,
So-
please, Bharti. Please, Bharti.
Yes, please.
Very simple question, but then it was an excellent talk. Very
Thank you, ma'am. Thank you.
studies and overview.
Yes, ma'am. Thank you, ma'am. Thank you, ma'am.
That question is that when we want a preventive surgery to be done, we usually recommend tubectomy, like self-injectomy,
Yes,
isn't
ma'am.
it? So that self-injectomy, rather than self-injectomy, if suppose we do only fimbriectomy, is this okay? Or
No,
do you recommend, is there any study that they say कि full tube has to be removed or only see the salpinx has to be missed, like fimbria has to be removed? Anything
ma'am.
very specific?
Yes, ma'am. Yes, ma'am. The thing is actually now the recent studies prove that the pre-invasive lesions of ovary, it is not arising from the ovary. It arises from the internal lining of the fallopian tubes, which starts from the isthmus till the fimbria it is there. So those tubal linings, that internal tubal linings has those pre-invasive cells, ma'am, which is a precursor for developing this ovarian cancer. That is the recent study, ma'am, actually. So we
That
have
has
to
to be
remove the
completed.
total tube. Yes, ma'am.
Does anything ascending of the cells from the vagina, is it any theory like that? From the vagina, the
Yes, ma'am.
endometrium?
There was a theory using the talcum powders. Using this talc was had an increased risk of developing this ovarian cancer ascending to this vagina, but it is not actually now proven. But still, we recommend it as an against of ovarian cancer, ma'am.
Okay. What about okay, something else? Stick.
Ah. Yes, ma'am. That is that serous tubal intraepithelial carcinoma, ma'am. This is that internal lining of the fallopian tube. That is tubal intraepithelial lesions, which will develop in the internal lining of the tubes, which will give rise to the ovarian carcinoma in later stage. And nowadays, we have to know that not only this ovarian cancer presents only in the ovary. Together, this ovarian cancer, fallopian tube with the stick lesions, and along with the peritoneal cancer, all together is nowadays called as this ovarian cancer, ma'am.
5 more minutes for a few more questions.
So, We
Bharti.
have
Yeah,
few
can I
questions in the
ask one
chat
question?
box,
Yeah,
ma'am.
yeah. Please, chairpersons, can they ask?
Okay.
Yes, Sujata.
You said IVF and endometriosis, they are high risk. So when should we screen them? Like after IVF conception or endometriosis patient?
Ma'am, endometriosis has a high risk of developing this endometrioid and clear cell ovarian carcinomas. So in that case, immediately after completing this IVF and after completing the pregnancy, the screening can start as early as 6 weeks post-pregnancy.
Okay. Okay, thank you.
Madhu, just chat
Yes,
for a
ma'am.
few more. Yeah.
Yes, madam. Rajatarangini, madam, thank you so much for that wonderful talk. It has been well appreciated in the chat too. There are some questions which asks if for high risk male breast cancer, what are the screening tests?
Ma'am, for high risk male breast cancer, we have to do this genetic testing. We have to do this BRCA mutations that should be started from the age of 10 years before the family member was diagnosed. And risk reduction surgeries like mastectomy can be done at the age of 35 years, beyond 35 years. The thing is, not only BRCA causes male breast cancer, it can also cause pancreatic cancers, prostate cancers, and various other peritoneum related cancers.
I
Mesotheliomas.
think that answers the question. And what is the sensitivity for CA19-9 and CEA markers, madam? How reliable are they as markers is the next question, madam.
Yes, ma'am. CA99 CA, when we see CA will be elevated in tumors like CA carcinoma of appendix. Okay, ma'am. And also all carcinoma of colon, they will have a raised CEA values. So when we have an ovarian cancer, when we have an ovarian tumor, that could be a primary ovarian tumor or that could have raised from a metastasis from the colon. So in that case, the CEA will be elevated, but even some mucinous cancers also can have the CEA elevated values. And when we see the CA19-9, it is clearly a tumor, which is actually this upper abdomen pathology like pancreatic cancers, gallbladder cancers, everything will have a raised CA19-9 value that could also metastasis to ovary. So there also, when we have an ovarian mass with CA19-9 elevated, we should also evaluate all this hepatobiliary cancers also. That is that
So
important.
that's more sensitive, but not very specific. So
Not
it's
very
important to
specific.
see
Ovarian.
other the CA2.
Yes, ma'am.
Great. And the next question in the chat is, can we recommend hysterectomy in high risk group after patient achieves menopause? And how can only hysterectomy with bilateral salpingo-oophorectomy help in preventing CA ovary, madam?
The thing already I told you, ma'am, when we do a hysterectomy, we remove the tubes also. So when salpingectomy, I told you, risk reduction salpingo-oophorectomy will protect you from 87 to 92% of ovarian cancer. Still, that 7% risk will be there from the peritoneal cancers. Peritoneal cancer is also now included in the ovarian cancers. So when salpingectomy, when we do, there is a risk reduction of only 65 to 70% by preventing that stick lesions from developing into the ovarian cancers. In that way, we can reduce the risk.
Okay, madam. Thank you. What important genetic studies are available to be done is the next question.
Important genetic studies, that next generation sequencing only we are doing, ma'am, where we have a wide panel of genes, more than 100, 150 genes we are screening. In that, somehow we will diagnose this risk of ovarian cancers, ma'am. That is the only one now we recommend it practically in our clinics.
Okay. The other question is, what about women undergoing multiple IVF cycles, madam? Do they come into high risk?
Ma'am, multiple IVF cycles, the thing is we are making that women to ovulate more and more, right? So when there is a theory called risk of incessant ovulation theory, which causes ovarian cancer. Repeated ovulation causes the breach of the ovarian surface, repeated inflammation and repeated elevated markers. So in that case, in future, they might have a little risk of elevated ovarian cancers, but it is not practically actually proven. It is not for everyone actually.
Okay. Thank you so
We
much.
can stop
And
with that, I think, no? Because all are coming about the Krukenberg and
Yeah.
and the bevacizumab, all those things are going in for a management. We'll call
Yes.
Raji again for a management of
Sure,
ovarian.
ma'am. Sure, ma'am. Updates in management, I'll do, ma'am, one day.
Yeah, okay. Thank you, Raji. Thank you.
Thank you so much, ma'am.
So
Thank
proud
you.
of you.
Thank you for the opportunity, ma'am. Thank you, ma'am. Thank you, ma'am.
Yeah.
Thank you, everyone, ma'am. Thank you, dear chairpersons, ma'am. Thank you, ma'am. Thank you.
so after that wonderful session, yet another great session on update in cosmetic gynecology. So here we have our chairperson of the second session and the speaker. May I request Dr. Vijaya ma'am to introduce the speaker and the chairpersons to the audience, please.
Yeah, have a great waiting because all this while we were talking only about IVF. This is the first time we are having a session on cosmetic gynecology, which is much more needed because every time there is a cosmetic conference, we don't go, ma'am. But now slowly we realize this is the need of the hour for a woman having a lax vagina or a sagging breast, whatever it may be. So this is very important in obesity and also this tummy tuck surgeries, everything. So I am just hoping for a good session. And let me introduce Dr. Pratibha, a consulting obstetrician and gynecologist from Maharaj Rural Multi-Specialty Hospital, Magagan. And it's a tertiary care unit, including the radiation unit and cath lab. She's the president of Gading Laj Obstetric Gynec Society, and she's the director of Sant Gajnan Maharaj Education Group. She has a high interest in high-risk pregnancy and conservative surgeries and prolapse. And yeah, very good chairperson.
Thank you, Vijaya ma'am.
Yeah,
Thank you, Vijaya
welcome,
ma'am.
Pratibha. Welcome, Pratibha. And let me introduce Dr. Vasanthi Neha, and she's an accredited speaker, president of the Nashik OBGYN Society, a vice president and clinical secretary of NOX. She has got a lot of awards from Vasantaram Gupte Award, Dronacharya Award in Reproduction 2024, and MS Signature International Award, Hirkani Award, and Nashik's Most Powerful Woman Award. Yeah, good. 2024, and treasurer of Western Maharashtra chapter of Indian Fertility Society. Yeah, very nice to see you, Vasanthi. Welcome. Dr. Alka. Alka is a senior consultant from Shalaka Hospital, Nagpur, and she is a practicing gynecologist for over 30 years. Lots of publications in menopause and Menopause Live, August 2013. Several chapters related to menopause and chapter on genital malignancy also. Member of International Menopause and Menopause Society of Nagpur and NARCHI and Vishaka Committee, Maharashtra. President NARCHI in 22-24 and member of Public Forum Committee in Foxy 2013 to 16 and various papers at national international conferences and creator of Suno Sahelian, the cervical cancer awareness talk in YouTube link. Yeah, welcome, Alka. Yeah, Poonam. Poonam is the director and professor of Superintendent of Kasturba Gandhi Hospital, Sevagram, Varda, and she has an advanced training from Sweden and JIPMER and Skill Lab training for EMOC and also from CMC Vellore. She's a core committee member of FIGO PPH workshop and she's the president of Varda Sevagram OBGYN Society, principal investigator of e-Partogram, very important for the PGs, and stillbirth and pre-viable birth defect project, WHO CRO, and low-cost salivary progesterone predicting preterm birth, and also Bill Melinda Gates Foundation. She's there in a member, EMOC and PPTCT investigation of hypertensive disorders of pregnancy. She's a tag member and she's a resource person for Government of India and GOM, and recipient of Best Doctor Awards on anemia and also EMOC projects, and given lots of oration throughout the international and nationally in IMA, Foxy, and also in Finland, Kenya, and London. And she's wrote several articles and chapters in international and national journals. Welcome, Poonam. Can we start, madams? The Poonam. Yeah. Bharti, can you start sharing your slides?
Yes.
I request Vijaya ma'am to introduce Bharti.
Bharti ma'am is the heroine of the second session.
Everybody is sharing, that's why I can't share.
No, now I am,
Yeah.
see your slide, ma'am. She's the head of the gynec department at Shri Hospital. She's a scientific director, embryonic IVF Pune, and national vice president of IFS 2022, and past national vice president of Foxy, and past president of IMA Pune, past president of POX, and ex-chairperson clinical research committee Foxy, founder executive member of Gynae Endoscopic Society, and founder chapter secretary in West Maharashtra, chapter IFS, executive editor in journal FSR, Foxy Star Awardee in 2016, Punya Ratna Award in 2014, Woman Icon Award in 2015, Inspiring Gynecologist in 2017, Shri Shakil Award in 2022. Ma'am, very inspiring CV, madam. Welcome you.
Thank you so much. Thank you so much. Now I will just share. Is it seen?
Yes, ma'am.
Yeah. So good evening all. Thank you so much for the introduction. And this is a great initiative. Thank you for the invitation. And thank you, my chairperson, Dr. Pratibha, Dr. Alka, Dr. Neha, and Dr. Poonam, being here at 8:30, I think 8:30. So thank you so much. And we had a very great session. First session was really very good. And this is also equally very different session. As Dr. Vijaya said, we were not bothered about this. We were thinking that, oh, this is not going to be so clinically applicable. And that's how slowly we started ignoring that or taking a least interest. And suddenly we realized that, it is going to stay. It is been going to be there only. So, and then everybody started realizing that we should know about it. So what is this cosmetic gynecology? I'm not going to talk about any breast or anything. It is just focused on the vagina. It is only the pelvic organ and pelvic thing. So so this is what we are going to see today. Cosmetic vaginoplasty. Change before the change. So why this is so? Because we know that there is a rising consumer demand. Consumer is coming first to you now with the demand, and that's how it is been a change because of the access to information. So society is becoming more egalitarian. That is, means all people are equal and deserves equal rights and opportunities. And delivery of healthcare becoming partnership between the patient's consumer's wishes and the doctor's professional opinion. And that's how we have seen that the quality of life is very, very important for every person. And bothersomeness is a condition which has been perceived by many patients now. Several factors factors can be contributed to increasing demand in the aesthetic dermatology procedure or cosmetic procedure, because the desire of prolonged youthfulness, self-image, economic abundance is there, technology and medical advances is there, media-driven demand high pressure advertising is always making professionals compulsion to undergo the cosmetic procedures, at least to learn. So the aesthetic procedures have become the need felt for each and every gynecologist. It was the same scenario for IVF also. When I started my IVF, and my IVF unit, when I started going to the bank for the proposal, they said, who is going to do IVF? I said, almost everybody who wants to have the child will go for IVF. So she was wondering, she was looking at me, the bank manager, and you know that today is the scenario. So we don't know tomorrow how the people are going to take it. So the professionals now understanding that there is a need felt. So huge growth in the use of social media, increased use of rating of images of self. You see, every now and then everybody takes selfie. All things, small things, even they have any problem also, our patients first take the photograph and send it to us. So self-monitoring apps, games, popularity of celebrity culture, airbrushed images, makeover shows, economy and social trends such as people retiring late, having completed their culture in the values, youthful appearance. This all is actually making. So these are factors for success. These are all in us to understand in P's. These are 14 P's of aesthetic practices are very, very important. Place, purpose, practice, and personal patients, procedures, photography, professional skills, performing clinical trials, product, patients record, publicity, promote, problems, protection. These are all actually very important when you start at aesthetic practice. Any youngster or any young gynecologist now would like to go into this 14 P's has to be kept in the mind, and this is how they should go ahead and start progressing or start going into the aesthetic practice. Why this happens is natural progression. Childbirth, hormonal changes leads to vaginal laxity, vaginal dryness, recurrent infections, involuntary urinary leakage, that is stress incontinence, decreases the quality of life and sense of self. And this is how, if you go and search professional versus popular, PubMed, you will see designer vagina less than 100 items. And if you go Google, it will be more than 37,000 items found in the laser labioplasty. So this is how it has been totally changed. If you look at 2010, the Great Wall of Vagina was being published by Jamie. And I was surprised to see also that these are so many different types of vaginas could be seen. So what is actually it is? So what is the perfect perineum? Why we have to counsel the patient, or what exactly has been happening? If you look at the clitoris, there should not be hypertrophy. There should not be no excess skin and wrinkles on the wound. If you look at the minora, it should be small in length and width, regular symmetric edges, not protruding beyond the majora. It should not. Fair color is okay. Color is absolutely not needed. Majora, it should be tight. There should not be laxity. Bright. It should be no wrinkles and rugosities, soft and hairless. Perineum, if you look, no scar should be seen. Long length of the perineum, that is very important, from the anus to the introitus, lower part. What is the length of the perineum? No wrinkles or rugose and no skin tags should be there. These all, if you fit into this, is called a perfect perineum. And where any aesthetic surgeon will start focusing, or whenever they do the aesthetic surgery, this should be a picture in their mind. Okay, this is what we want to give to the patient. So this is the perfect perineum. So why the patient comes to us? Because of her within problems. Urinary dysfunction, often we used to neglect or we didn't have the answer to the patient. Stress incontinence, mild. Sexual dysfunction, fecal incontinence, pelvic pain, vulvar or vaginal itching or pain, abnormal vaginal discharge, or cosmetic issues like looking good or sagging breast, pregnancy stry marks, or other moles or scars. And vulval diseases, very important disease, lichen, warts, and others. So these are all her within problems which gives her to come to your practice or to your table. So why tissue ages or laxity is there? You know that pregnancy and the childbirth is the main issue. Smoking, obesity, significant weight reduction. Nowadays, there's a fan that at the time of say marriage, they will reduce and then immediately it will get. So this is significant weight reduction will make the tissue aging and laxity. Genetic, menopause, and low estrogen status. So these all things will have a problems with the patients. What are the treatment options? Till now, we knew only pelvic floor exercises, that is Kegel's exercise, which is not help. Patient, if it is help, it is very, very less percentage, and the patient's continuity is not there. Electric stimulation still is not working. Same, it's like pelvic floor exercises. Conservatives, they have tried implants, medications, but it did not work. But the surgery, open or lap, is been definitely playing a big role. So what are the cosmetic surgical procedures you can do for these patients in this area? If you look at the mons pubis, you can do liposuction or lifting. Clitoral region, you can do the excision, that's foodplasty. It is called excision of the prepuce skin. Labia minora, you can reduce by reduction in labioplasty. If you look at the labia majora, you can augment it via autologous fat transfer. Skin tightening can be done by resection of the loose skin, or varicose vein if she has, you can do the reduction with the sclerotherapy. In the vagina, you can have a vaginal tightening, a vaginal rejuvenation, and you can have a G-spot amplification or enhancement. In non-surgical procedures, like these were the surgical procedures, non-surgical procedures, you have a stand tall is vaginal rejuvenation, stress incontinence grade 1 and 2, post-delivery rehabilitation, change before the change, post-menopausal patient, vaginal dryness and recurrent vaginal infection. This is very commonly patient comes. We have almost 250 patients been done. And in that, I see 34% of the patients are with recurrent vaginal infection, where they kept on trying with one medication from one gynecologist, another gynecologist, and they fed up with that recurrent. And believe me, it makes wonder if they go with the laser treatment. Lichen sclerosis, another same situation. Medicines, tablet, ointment doesn't work, but the laser surely it works in this. G-spot augmentation, O shots, vulval skin tightening, and vulval bleaching. These all are non-surgical. So how to go ahead about it? This is an algorithm. When there is unappealing or uncomfortable external appearance in all this area, like labia majora, clitoris, labia minora, majora, mons pubis, or hymen, this is the way you go. If it is excess, you do resection. So this is the algorithm. You keep it in front of you and you can keep on going. Hymen reconstruction, hymenoplasty can be the option. If it is uncomfortable or decreased sexual gratification, patient, while she comes to you is very, very important. Her history is important. Her counseling is essentially important in the cosmetic surgery. If it is a loose vagina and increased sexual gratification, you can have options surgical as well as non-surgical. You can discuss with the patient and accordingly you start giving the treatment for the patient. If it is dry, irritated skin also, you have a non-surgical options. Or hyperpigmented, it is non-surgical. So this is the way the algorithm should be there in front of you that gives you what to do. So suppose if the patient comes to you for labia minora, beige resection, this is the way you have the picture of photographs and you do the labioplasty accordingly, the stepwise pattern. So this is the another one. It's a clitoral hood resection. If you can see, this is extremely uncomfortable to the patient. We never think that this could be so uncomfortable, but this is very uncomfortable. And the patient can go with a clitoral hood resection with labioplasty, very systematic way. So these are the labial blood supply, how you see which section has to be taken. This all actually is been in these two books. If anybody wants these two books, I can forward my number. You can note down 9822043112. These are the extremely good books, extremely aesthetic vaginal plastic surgery, how to select the patient, how to counsel the patient, what options has to be given to the patient, what is the surgical procedure, a stepwise surgical procedure. Every figure is been so clearly written in that book. And what post-operative care has to be done for patients' expectation, what has to be done. Each and everything is written in this book, Aesthetic Vaginal Plastic Surgery. I have a soft copy, both of them, female genital plastic and cosmetic surgery. Please download them whenever a patient comes. And if you want to start your practice in this aesthetic area, you must have these two books, extremely good books to have. So cosmetic laser vaginal procedure is a new frontier in the gynecology. So what happens with the laser? So laser ablation of vagina is actually a laser assisted procedure which is designed to improve the vaginal irregularities through vaporization and thermal effect. So what happens first is the ablation. Ablation will immediately contract and remove the tissue damage. And then thermal effect heats the tissue and which promotes and improves the tissue growth. So this is a new kid on the block that is called fractional or pixelated CO2 laser therapy. It's truly non-invasive and very revolutionary. Completely changed the picture of aesthetic surgery. So what it does, it is a family pixelated CO2 microablative laser. The laser beams passes through, these are the laser beams which pass through a pixelated holographic lens forming 9 by 9, very, very small spots. Thermal effect is achieved in the microscopic columns surrounded by spared tissue from which the healthy cells will be recruited and accelerated to give a healthy healing process. So what happens? First is a thermal damage. The second is a superficial shrinkage. The third will be deep aseptic wounds will be created, and then it starts collagen remodeling to the patient. So the thermal effect is achieved in the microscopic columns, and in that the surrounding tissue remains intact, but that surrounding tissue will give a healing effect, and that will produce a new collagen, and that new collagen is formed because of the heat shock protein. That's extremely important in this. So this is the way the laser goes. Now it is a robotic laser. So you need not to do anything. Everything is being automated, and it keeps on going exactly at the level it has to go. You have to just monitor and you have to apply on the screen, or the treatment modules has to be, you have to prepare and you have to be. So these are the micro columns goes, patient doesn't even feel anything. This goes like this. The surrounding tissue is good. Because of the heat shock, it starts giving the collagen, and you will see the complete difference, especially when the patient comes mild SUI. It is rewarding. She will not have to undergo any surgery. So histological remodeling and vaginal rejuvenation and involvement of heat shock protein 43, 47, and 70 in the localized area increases the specific cytokines, and which consequently activates the fibroblast to produce new collagen and new blood vessels in this patient. So what happens when you do the laser treatment for the patient? The first 48 to 72 hours, patient will actually have acute thermal damage phase where she will get the edema. So whenever you do vaginal rejuvenation for these patients are very happy. 72 hours, they say, I'm feeling that there is something increased in my vaginal thickness. So that is because of the edema. So release of chemical mediators will be there, and the collagen will shrink first. Then next 30 days, there is a proliferation phase. So fibroblastic recruitment will occur, new dermal molecular matrix will appear, and new collagen fibers will appear. And this is a very important, that 30 days means that first month is very important, that the patient will have proliferation phase. and then it starts. That's why we always say there are 3 sessions has to be taken. Number 1, 0, 1 month, and 2 months. That way it gives it 3 sessions. And the 3rd session will have a remodeling phase. And that happens maybe after 1 month or 2 months or 3 months. But the mature collagen fibers will occur and a new elastic fibers will occur in her body. And this is how it happens. If you see very carefully, this is epidermis and this is a dermis. So when the elastin, this is a collagen and elastin fibers, whenever your age happens, what happens to that is elasticity. This all starts reducing with aging or obesity. You see, this will go deeper like this, and that's how you get the wrinkle here. So this is the wrinkle. And what happens with this, when you start CO2 laser, it removes the abnormal upper tissue, which is this tissue, and it stimulates the new collagen growth in the dermis and effectively restructures and restores the stage like it was undamaged. And this is how the new collagen will come. The moment new collagen comes, you know that this wrinkle will disappear. And this is how that called collagen remodeling process, and which is very, very essential in the laser treatment. So Femilift is an FDA-approved pixelated CO2 laser. Is designed and invented by Alma Laser to treat vulvovaginal dryness, vaginal laxity, mild to moderate urinary incontinence, bleaching, and vulval disease. So if you see the different previous, before, and after. So this all can be achieved with the laser. What you should do, pre-treatment evaluation is very important. Full medical obstetric history should be reported. Vaginal health index questionnaire has to be done to the patient. You must know what is exactly is her level of understanding. Female sexual dysfunction index has to be, again, patient has to feel. Pelvic floor dysfunction index is there. So there are 3 forms which we give to the patient, and they feel, and accordingly we understand what exactly is her situation. Sonography, pregnancy test, and cough test. These all tests has to be done pre-treatment evaluation. Treatment protocol, it's an office procedure. No anesthesia is required. Laser application on the vaginal canal, 360 degrees. It goes only under the mid-urethra. 30 watt, 50 to 120 millijoule, and 0.5 mega. It's pre-menopause. And if it is a post-menopause, we give a 30 watts per 20 to 50. So we can't hit more in the patient who is post-menopause. 3 passes, you go, come back, go. This is a 3 passes. 3 sessions, 1 month interval, 1 memory session after 1 year, and repeat the course after 2 years for the patient if it is needed. So procedures you can do: involuntary urinary leak, vaginal itching, vaginal laxity, white patches on the vulva, chronic vulvar pain, vaginal infection, vaginal dryness, or recurrent urinary tract infection. Stress incontinence, especially, you see, this is what happens. This is actually the culprit or the area of interest. When the collagen starts increasing, this automatically starts giving her the relief, and she starts feeling that's been actually good. Stress incontinence is actually underestimated. People, they don't say. Females usually hide. Nowadays, they use diaper. And this is all actually, they don't know what exactly has to be done. Surgery, they have been scared. They don't want. But this is the best way to go ahead. And this is actually seen in the literature, how incontinence is been helping and how the patients are getting a relief. Laxity, this is the way it happens. You know that edema happens, and then collagen happens, and the tissue actually starts growing, and that's how it starts giving you the feeling of tightness, and that is what the vaginal laxity will get actually cured. White patches on the vulva, that is actually lichen sclerosis, extremely useful for the patient. I never knew when the patient actually came first time to me with lichen planus, sclerosis and planus. I didn't know what to give to the patient. Same like how we give the ointment and everything I had given her. And I didn't know what to do next. I had just simply told her, okay, this is what I can do you maximum. And when I went for the training of this laser, vaginal laser treatment course, I saw so many patients over there coming. I said, does it really help? She said, yes, it helps. You see, you ask the patients, they will give you the answer. And this is how we started over here, and it is a blessing. This is another area of recurrent vaginal infection. It's extremely common. And we keep on giving them the tablets and medicines, and from one end to end, another doctor, she keeps on going. And that patient doesn't get relief. So this patient's recurrent vaginal infection, Femilift of the laser treatment is a boon for them. Provided you have to, infection has to be treated initially. First, you have to treat the infection, and then the second, when she has been completely treated, give this, she will not come back. So this is what is the recurrent vaginal infection. So surgery, longer recovery period, but this laser treatment, safe, quick, and effective. So this is how it's the machine, very slick machine, and this is the actually laser arm. So this is what we do with the patient. So this is the way it works, like as I told you, and this goes into the tissue. We explain the patient like this. This is the way you are going to happen. There will be little warmth in the inside, and whenever you feel it is too much of heat, we can reduce that settings. So this is minimal invasive outpatient procedure. It's called coffee break procedure now. Easy and safe to perform, effective with immediate effect, minimal downtime with rapid healing, and single use, and a very hygienic vaginal probe, because every patient will be changed the probe. So these are the comparison. We all know that. So surgical treatment versus the laser treatment, because it's very simple. So you can go. So this is vaginal fractionated CO2. See how the things will happen. This is atrophy and menopausal, and this is how you get the treatment options later on. So this is how the pre-treatment, post-laser treatment, and the post-laser treatment patient's neovascularization happens to the patient. So these are all studies, especially the patient who has been vaginal dryness post-menopausal. It is again a boon for the patient. Believe me, it makes a lot of difference to them, because the dryness almost kills them. So this is how the laser happens, and this is our teacher who actually taught us for this aesthetic procedure. So thank you so much for your patient listening. Any questions?
Madam, disadvantage. What is the side effects?
If you take a surgical and non-surgical, surgical, you need to have the skills. Very important, because that area is very small area. If you see, I have given the pictures initially of very small area. This is a plastic surgery. You need to be very cautious about it, because the effect which you give the incision and everything has to be very careful. Your suture material is very important. A very thin, and post-operative care is essentially important. So it needs like an IVF. Now, if Madhupriya is there, we know that, see, IVF also, you need whole center completely devoted to that, like your patient's history, then the counseling, and then post-counseling, because you have a failure. Exactly that. The laser or the cosmetic gynecology, you need counseling. Unless patients, although 3 indices are not there in front of you, you cannot keep going. About the surgical procedure, complications are very few. Only the dissatisfaction, like what she has in her mind, how my vagina has to be seen. If it is not been as per her expectation, she'll be disheartened. So you have to beforehand tell her how exactly it is going to look. That non-surgical laser, 0 side effects. There is no side effect at all, not at all, because nothing we do actually there. But the expectations of the patients should be very clearly understood by patient and yourself. You should know which patients are indicated, which patients are not indicated. If you understand that, I think there is no side effects at all.
When can they start their sexual relation after this laser or whatever surgery?
Laser immediately she can. Laser immediately she can have. For Open surgery, she'll require time because there is a healing, there has to be healing. But see, few surgeries like labial hoodplasty, that clitoral hoodplasty, have you any time see that it is so disturbing? That is completely disturbing. But that has to be in completely. Even if suppose you're sitting, also it will be bothersome to those patients. So those patients you need to, but that requires a lot of planning. There is whenever we start surgery, we with the pain we mark them where exactly my incision is going to be there, how it is to be completely reconstructed again back. The anatomy has to be very perfect before doing that surgery. That's the only thing. Labial tightening, labia majora tightening, very effective and no side effects at all. Discoloration, extremely good. Stress incontinence, mild, extremely good. Means it's a body only for the patient. And recurrent vaginal infection and vulval atrophy, that is dry vagina, especially postmenopausal, postmenopausal patients, it is a boon. But you must remember that there are different probes. You cannot keep on using with same probe because that one probe, which is a bigger probe, cannot fit into the dry or the postmenopausal lady. She has to have a small probe and she has to, according your settings should not be more high to her because the vaginal thickness is very thin, that vagina is, and she will experience that heat very quickly. So these all things has to be, it's like you have to have a proper training.
The chairpersons wanted some questions, madam. Poonam, madam.
Yes.
Thank you so much, Dr. Bharti. What a wonderful lecture. Seriously, I mean, this is the time when we have to really think about cosmetic gynecology. All of us, like, you know, right from adolescent till the age we go into menopause, the moment you talk the word sex, people get, you know, either they, you know, sort of, nobody really talks about it actually. Now, see, husband wife are husband wife, and they may have lot of fantasies, they may have lot of you know, liking, dislikings, and if they want, why not? You know, that should be the main this thing. I'm talking about the developed world. I was in Saudi Arabia for nearly 7 years, where I truly done cosmetic gynecology, where, you know, they would caranculi metiformis and ensure that you do some hymenography, plenty of perineography because they have multiple births. Coming back to India, I'm seeing lot of labial fusions, for which we are doing cosmetic surgery. We're saying huge big labia majora, which we are reducing, the clitoromegalies, which we have been doing. So there've been too many where we have done. I have just two major comments, that whenever we are doing these surgeries, the partner has to be taken into consideration. We have to have the consent and the compliance has to be there. I have seen a very bad case where, you know, we did the surgery, vaginoplasty, and, you know, the girl came back again with all ruptured, this thing bleeding and all that stuff. My submission would be that whenever we are doing these kind of cosmetic surgery and the girl is married or the woman is married, there has to be consensus from the husband. Consensus not particularly for operation, but for the compliance. And there are certain things which we have to look into. Not every vagina is same, so the dilatation, the way you reduce or whatever, it has to be individualized. And the maxon sutures, which are very prevalent in using for these cosmetic gynecology cases, would really be very wonderful. So these were some comments which I just wanted to.
Thank you, Poonam. Pratibha, you wanted.
Very nice lecture, Bharti ma'am, with nice pictures. But in practice in our area, we are working in a rural area, and there is need to ask some leading questions because they are not telling. Many times, husband is coming inside the cabin and he is telling, "Sang naga, sang naga." So you tell something. Means many times they are not, there is need. The only cases, the iatrogenic menopause. After the hysterectomy, they are with us for 3 months, 4 months. And that time we can tell them, we can advise them. But sometimes we fail to tell them that time. Even after 6 months, they are coming and there is no history of intercourse after hysterectomy. Means such situation is there in rural areas. And they are not telling their problems. That's why I feel there is a need to ask them leading questions. That is the thing. And another one thing, is there any contraindication for your laser treatment? Because most of these menopausal patients, they may have hypertension, diabetes. Is there need for tight control of blood sugar? As there may be chance of infection even after the laser. Is there?
Infection is the contraindication. Infection should not be there at all. So that is very, very important.
Means there is a tight control of sugar should be there before procedure.
That's
Otherwise, there is no such contraindication.
No, no.
Neka, you want to add on something?
Yes, madam. First of all, let me thank you for giving me this opportunity. The most important, because these two, Dr. Bharti and Dr. Poonam, both of them are my mentors. And it was a great opportunity to share with them the diets, with them. So thank you for that, both of you, Dr. Vijaya and Dr. Madhupriya. And I wish both of you the best luck for your coming elections. Now coming back, both the sessions were excellent. You are really selected right topics and right speakers. Regarding Bharti madam, she is always a great orator and a very, I'll say, a great faculty. Madam, I will just like to ask two questions for you. In the recurrent vaginal infection, the young patients, reproductive age group patients, how does the laser help them to cure the vaginitis? What is the science behind it? And second question was, in the patients of SUI, do you need to do certain urodynamic studies to diagnose the exact type of or the cause of the SUI and then treat accordingly?
Thank you, Neha. Neha, it's a pleasure, always a pleasure to be along with you. And she's a very scientific person. She will make me awaken over here and make people also. How?
Yes.
Number one question, the recurrent vaginal infection. So what happens actually in the recurrent vaginal infection? The patient vaginal rugosities, either suppose if the patient is, say, menopausal or postmenopausal patient, or the patient has got a very less rugosities. You all know that the rugosities has our lactobacillus, that is our army, which actually, because that site itself is an opportunistic infection. Their urine, their menstruation, their intercourse, their motion, everything is over there. So that site itself is an opportunistic infection site. So still we don't get so much of vaginal infection. It's only because of our army, our own lactobacillus. Now lactobacillus, where they stay in the rugosities. So that's how what happens. The patient is postmenopausal, or the patient is too cleanliness is there, she will remove that her lactobacillus again and again. And this is how, or some patients has a thin vagina only. See, it's not anybody's hand, but like our skin, everybody has got different vaginal thicknesses there. So if she has thin vagina, the rugosities will not be there, the lactobacillus will not be there. What happens with the laser? The moment you start giving her the laser, as I said you, first shrinkage will happen, edema will happen, and neovascularization will, and the collagen will start increasing. The moment collagen starts increasing, vaginal thickness increases. And that's how that vaginal tightening also happens, is because of that only. And the rugosities increases. The moment your rugosities increases, your lactobacillus, you are giving treatment. You are already putting her onto the, this probiotic. So this all will stay over there, that lactobacillus. And that's how she starts fighting on her own to that infection. And believe me, it is extremely good. Patient will tell on your own. This is so rewarding, especially for recurrent vaginal infection, which we never believed initially. But the patient's video recordings I have. Like she said, what happened before, how many times I had gone to the gynecologist. Now What is happening to me? She's so happy there. So this is how is the concept of recurrent vaginal infection. The second question you asked about the stress incontinence. The stress incontinence,
Right.
again, stress incontinence, you know that the mid urethra, actually there is a gap there. So that the moment you start laser treatment to heal, it's because of the first edema, then shrinkage, and then the neovascularization, collagen increases. The moment collagen increases, that gap she will have the strength there. But it has to be mild. Very importantly, it has to be mild. You have to do the urogram. If the patient comes with a cystocele, no, it doesn't work for these patients. It has to be just mild. So for this, every patient post delivery, I'm again and again emphasizing, change before the change. Post delivery, if suppose they have these 3 sessions postpartum, they will not have that stress incontinence, especially patient who has undergone normal delivery. And it is absolutely, over a period of time, it will be included. You see that all mother and child, all they will have a laser treatment incorporated in the post delivery, because postpartum depression, postpartum laxity is very known. Everybody, mild incontinence, almost 75% of the ladies has.
Have you any experience about the failed SUI surgery and there is a benefit from that? Any experience? Even after the failed
Okay.
SUI surgery, like TVT
Failed
taper,
TVT.
birch, sometimes it fails.
Yeah.
And
Birch
after
medical.
that, is there any experience? You have any experience? There is some
With the
recovery
laser?
after
No.
laser?
No. See, Dr. Pratibha, basically we don't take
We
those
don't do for
patients.
the severe cases, only for the mild cases.
Because see, it will not tighten the tissue to
But we
that
can
level.
try, no? I think we can try even after the failed cases.
But then we have to explain the patient like
Yeah,
that.
we have to explain them.
And it is not very expensive also.
Yeah,
See,
that's why we can try.
5,000 or 10,000 rupees per session she has
Madam,
to see.
Madam, sorry to interrupt.
Yeah.
I'm Dr. Meena, trained under Professor Rajamaheshi, Madam. For failure cases, I don't think, as Madam said, Bharati, Madam, it doesn't work, Madam. It is only for mild SUI.
Yes.
This is what my experience is that it works only for the mild. I've never seen patient who has a moderate to severe. We refuse those patients. I said, no, beta, there is some other treatment for you. It is not this treatment. There are different modalities.
Yes, Sujata, you want to ask something? Sujata was there. Alka?
Yes. My questions are that first of all, I extend my sincere thanks to all the speakers and participants and for selecting such a wonderful topics. And really, Bharti, you were amazing. Miss, I was thinking I am sitting in a class and you're teaching and you made that cosmetology so easy for me. I have done some very few years back, but that time I was not interested in too much. I was more in the high risk pregnancies, but excellent. But my question is that I thought it may or may not. What is the role of stem cells in this cosmetic surgery?
I think somebody had asked the question in the chat box also.
Yeah, it's me.
So Botox, somebody says Botox or PRP. It definitely has a role, especially when you give a patient who has a stress incontinence and the patient who has a vaginal rejuvenation laxity. It definitely has a role. So you can additionally, with your laser treatment, you can additionally provide that. It gives a prolonged effect. So it has the role. Okay.
And one more thing I want to add that yes, this is going to be days are not months. As you said, after postpartum, there will be many women who will be coming for these surgeries. Yes, but ethical considerations also has to be done, and not much advertising should be done for this. That's what my commercialization of this surgery should be. Yes, that's what we should be considered as a health providers and doctors.
My fifth slide, Dr. Alka, was professionals and Google. PubMed has only 100 attempts.
Yeah, yes.
Google has 37,000. So it has gone, some things sometimes has gone beyond professionals. So it is already gone out of our hands. Can you believe in Pune, we had a study done. Dr. Poonam actually was talking about the hymenoplasty. In Pune, we did the study. And you tell me how many hymenoplasties may be happening in Pune? Can you guess it? Per month. Can you guess? Just guess.
No
Tell
idea.
me guesswork. Just guesswork. How many you think hymenoplasties have happening? In
Some
our
100
era,
per
to
month?
hardly.
No.
Tell me, because I remember Dr. Poonam, Dubai, these all people only used to come for second marriage and these all things, right? Now, how many have a living relationship?
Yeah, that's the
90%, 90%. Every female comes, and beautiful hymenoplasty. Good, you will not believe it is exactly, if you know the technique, surgical technique, exactly like how the vagina it was. Hymenoplasties have been done in Pune more than 5,000. More than 5,000, I'm telling. So, आप कहाँ हो?